Chairpersons, ladies and gentlemen, good afternoon. My name is Chen. I'm a professor of medicine and the director of the Lehigh Heart Institute at the University of Minnesota. First, I would like to thank Professor Βασιλικός and the organizing committee for the gracious invitation to speak at today's conference. This afternoon, I will be speaking on P-wave parameters and indices, current status and future directions. Today's talk will be based on excerpts from a consensus document that many of us in the audience, including Professor Ikeda, Professor Βασιλικός, published earlier this year in Circulation, Arrhythmia, and Electrophysiology. About 2 years ago, I had the wonderful opportunity to chair a writing group representing members from 2 international ECG societies, namely International Society of Electrocardiology and International Society for Holter and Non-Invasive Electrocardiology. After 2 years of work, we finally published this paper in Circulation, Arrhythmia, and EP, and we are particularly proud of this document because it truly is an international document with members coming from all continents in the world, except for Antarctica and Australasia and Oceania. Other than being principal investigator on NIH grants that support my work on atrial fibrillation and atrial myopathy, I have no other disclosures. In the next 15 minutes or so, we will touch on the following. We will start with something simple. What are P-wave parameters and indices, and what are the definitions? Then we will spend just a little time on anatomical considerations. We will spend most of the time looking at evidence linking P-wave parameters with higher risk of relevant clinical outcomes, namely cardiovascular disease and dementia. We will also spend time looking at how, by considering P-wave parameters, we can enhance prediction of clinical outcomes. And finally, we will spend time looking at some future directions. First, definitions. Let's start with interatrial block. Shown in this panel A are normal, partial interatrial block, and advanced interatrial block. Partial interatrial block is defined on the ECG as a P-wave duration greater than 120 milliseconds. Advanced interatrial block, also known in the literature as Bayer syndrome, has 2 criteria. First, P-wave duration that's greater than 120 milliseconds, and in addition, in the inferior leads, namely 2, 3, and AVF, there are biphasic P waves with a terminal negative component. Next, PT-FV1. We have read about this in the literature, and it's also one of the talks in this session. And this is defined as the product of the width and the height or the magnitude of the negative component of the P wave in lead V1. And by convention, a PT-FV1 that's greater than 40 millimeter is defined as abnormal. Next, the P wave axis. This is measured on the frontal plane, and by convention, anything between 0 to 75 degrees is deemed to be normal, and anything outside this range is abnormal. Now, less commonly seen in the literature include the P-wave voltage, and this is defined in lead V1, and it is considered to be abnormal if the P-wave voltage is less than or equal to 0.1 millivolts. And then finally, P-wave area. And this is, again, a product, and this is defined on lead 2. And this is defined as half duration of the half of the multiple of the duration as well as the voltage. And anything that is greater than 4 milliseconds millivolt is considered to be abnormal. So let's look at some anatomical considerations, and really this can be a whole topic by itself, but I will focus on one that fellows commonly ask me in the clinic. What is the basis of the abnormal PTFV1 that is so commonly reported in the literature? This is a figure that we can see in the consensus document. And here is a transverse section of the heart looking from the top. The key concept to understand here are interatrial connections and what is the nature of atrial depolarization from the right atrium to the left atrium. In a normal situation, there are posterior fibers posterior to the fossa ovalis that will allow atrial signals to conduct to the left atrium, as well as the Bachmann's bundle, which is situated superiorly and anteriorly. With atrial disease, the thin posterior fibers will become interrupted first, which means then atrial signals from the right atrium will propagate to the left atrium via the Bachmann's bundle, and therefore there is a prominent posterior force in the left atrium. Hence, this terminal negative deflection in lead V1, in the P wave in lead V1. So this is the anatomical basis of abnormal PTFV1 due to atrial disease interrupting electrical propagation through the posterior fibers. Now, we're going to spend most of our time looking at association with clinical outcomes and also enhancing prediction of clinical outcomes. Shown here is the main table, table 1, summarizing the key studies linking abnormal P-wave parameters to the risk of ischemic stroke. And let's start with the work by Dr. Elsaid Solomon at Wake Forest University, a good friend and colleague. In this paper published in 2009, Dr. Elsaid Solomon provided one of the first lines of evidence linking PTFV1 P-wave area to a higher risk of ischemic stroke. However, in this early work, atrial fibrillation was not accounted for. Dr. Huma Kamel, a neurologist at Cornell, followed up on this early work and this time focused mostly on PTFV1 and showed in multiple different settings and cohorts that abnormal PTFV1 is associated with higher risk of ischemic stroke, and this time accounting for atrial fibrillation. Next, a previous fellow of mine, Dr. Ankit Maheshwari, who is now junior faculty at Penn State, focused on P-wave axis and showed that not only is abnormal P-wave axis associated with a higher risk of ischemic stroke, but it can also improve prediction of stroke, and more on this later. And finally, good friend and colleague Dr. Martinez Sayas in Spain focused on advanced interatrial block, and in this study showed that advanced interatrial block in people without atrial fibrillation is associated with close to 5-fold higher risk of ischemic stroke. Now, let us keep in mind that just because a biomarker is associated with a certain clinical outcome, it doesn't necessarily mean that by considering that particular biomarker in a clinical prediction rule, we can necessarily improve prediction of that particular outcome. A case in point is atrial fibrillation. We know from multiple studies that abnormal P-wave parameters, including prolonged P-wave duration, abnormal P-wave axis, abnormal PTFV1, so on and so forth, are associated with high risk of AFib. But in this study that was published, including the Framingham Heart Study and the ERIC cohort, P-wave duration, P-wave area, and P-wave terminal force, they were not associated with a significant improvement in model discrimination nor risk classification of ischemic stroke. By contrast, by considering abnormal P-wave axis, we can improve prediction of ischemic stroke in people with AFib. So let's spend some time examining this concept. One of the focus areas in my lab at the University of Minnesota is to define the role of abnormal P-wave parameters in predicting cardiovascular outcomes such as AFib and stroke. And one particular favorite of ours is the abnormal P-wave axis. Our early work in this area was led by Dr. Ankit Maheshwari. And we are interested in abnormal P-wave axis for two main reasons. First, of all the abnormal P-wave parameters, it is the one that is routinely reported on all standard 12-lead ECGs. Second, we have data to show that of all the P-wave parameters, it is the one that is most strongly associated with underlying left atrial enlargement and impaired left atrial function. Now, I mentioned earlier that normal P-wave axis is defined as between 0 and 75 degrees. This early work that was published in Stroke in 2017 was based on the ERIC cohort, or the Atherosclerosis Risk in Community study, that enrolled close to 16,000 middle-aged individuals towards the end of the 1980s from 4 USA field centers. The University of Minnesota School of Public Health, the institution that I'm at, is one of the key field centers of the ERIC study. And since their baseline exam in 87-89, many follow-up exams have been completed. In this paper, Ankit was interested in two major outcomes: definite cardioembolic stroke and definite thrombotic stroke. He found that the presence of abnormal P-wave axis was associated with twofold increased risk of ischemic stroke, independent of stroke risk factors, including atrial fibrillation. Although he found that abnormal P-wave axis was also associated with a higher risk of thrombotic stroke, this association was weaker. Next, he categorized definite thrombotic stroke into two subtypes, lacunal versus non-lacunal stroke. And this is where the findings became even more intriguing. He found that the presence of abnormal P-wave axis was significantly associated with a higher risk of non-lacunal stroke, independent of stroke risk factors, including AFib. But by contrast, abnormal P-wave axis was not associated with definite thrombotic stroke, now definite lacunal stroke. So collectively, these findings indicate that the underlying abnormal atrium or atrial myopathy, as indicated by the presence of abnormal P-wave axis, is associated with a greater propensity for cardioembolism leading to ischemic stroke. Ankit then decided to follow up these findings in another line of investigation to determine whether adding these P-wave parameters to the CHEST-VASc score would improve stroke prediction in AFib. And here, Ankit interrogated four key parameters: prolonged P-wave duration, abnormal P-wave axis, advanced interatrial block, and abnormal PTFV1. The primary analysis was conducted in ERIC, and we validated findings in the MESA study, which is an independent community-based cohort study in the United States. So this table shows the association of the four P-wave parameters with ischemic stroke in people with AFib in the ERIC study. Of the four P-wave parameters, only abnormal P-wave axis and advanced interatrial block were significantly associated with a higher risk of ischemic stroke after accounting for the variables in the CHEST-VASc score. Next, Ankit added each of these P-wave parameters to the CHEST-VASc score to determine improvement in model discrimination as measured by C-statistic, and improvement in risk classification of ischemic stroke as measured by the NRI, which is the net reclassification improvement, or the relative IDI, which is the integrated discrimination improvement. And he found that of the four P-wave parameters, only abnormal P-wave axis resulted in a significant improvement in C-statistic and risk classification of ischemic stroke. So, quick summary. Of the four P-wave parameters, only P-wave axis was significantly associated with ischemic stroke, independent of CHEST-VASc variables, and improved stroke prediction in people with AFib. Based on the regression coefficients, we then assigned 2 points for the presence of abnormal P-wave axis and thus creating the P2 chest vest score. We then tested the P2 chest vest score against the conventional chest vest score in both Eric and Mesa, and indeed, we found that the P2 chest vest score was superior to the chest vest score in terms of model discrimination as well as risk classification of ischemic stroke in both Eric and Mesa. Now, we presented findings for stroke. What about dementia? So this is work led by Dr. Alejandra Gutierrez, a previous fellow of mine and is now junior faculty at the University of Minnesota. And in this paper that was published in 2019, Alejandra was interested in PTFV1, P-wave axis, and P-wave duration. And she found that all the P-wave parameters were significantly associated with a higher risk of dementia after accounting for dementia risk factors, including clinical stroke. And this is in the order of 40 to 60%. Now, keep in mind that P-wave parameters are, after all, ECG surrogates of atrial myopathy. There are other surrogates, for instance, echocardiographic markers. So we followed up on this work in 2019 with this work that's focused on echocardiographic measure of left atrial function and showed that this left atrial function, lower left atrial function, is associated with higher risk of dementia. And this paper was published earlier this year in JAMA. The quick summary is that measures of left atrial function, whether it's by strain analyses or volumetric analysis, in other words, left atrial reservoir strain, conduit strain, contractile strain, and emptying fractions, were significantly associated with incident dementia independent of AFib. However, left atrial size was not associated with dementia. And this paper was published by a PhD student of mine, Wendy Wang, whom I'm pleased to say is staying on as a postdoctoral fellow in my lab. And here's a picture of Wendy presenting as a STEMLA finalist at the American Heart Association scientific sessions 2 years ago. So in this table, Wendy looked at the free strain measures and categorized them into quintiles, with the highest quintile serving as the reference, and found that for all three measures, the lowest quintile was significantly associated with higher risk of dementia after accounting for dementia risk factors. We also performed mediation analysis to determine to what extent atrial fibrillation actually explains the association between left atrial function and dementia. And we found that atrial fibrillation actually plays a minimal role. In the mediation analysis, the highest mediation was only 1.6%, minuscule, and this is for left atrial contractile strain. We also constructed a restricted cubic spline to visually display the relationship between left atrial reservoir strain and incidence of dementia, and we observed that the relationship is actually not linear, presenting us the opportunity to perhaps identify a possible binary cutoff to classify abnormal left function. And here we have some preliminary evidence that LA reservoir strain of 27% might be a possible cutoff, because below that, this gradient increases steeply. So, future directions. I'm sure everyone is thinking about this. Could we contemplate a clinical trial to test anticoagulation to prevent stroke or dementia in people with atrial myopathy in the absence of AFib? Now, this is not a completely novel idea, of course, because we all know that the Ikeda trial is ongoing, funded by the NINDS, the Neurological Institute. But the Ikeda trial is a secondary prevention trial. The primary objective is to test the hypothesis that the apixaban is superior to aspirin for prevention of recurrent stroke in people with a history of cryptogenic stroke and atrial cardiopathy. Now, it's a biomarker-driven trial, and we'll get to the biomarkers in a minute. Recruiting over 2.5 years at 120 sites in the StrokeNet consortium. Minimum follow-up is 1.5 years with a maximum of 7 years. And these are the 3 biomarkers, namely PTFE1 of greater than 5,000 microvolt millisecond. Second, serum anti-proBNP of greater than 250 picogram per mil. And finally, a left atrial diameter index of greater than 3 centimeter per meter square. Now, I'm sure this is obvious to everyone that the subjects who will be enrolled into Ikeda are going to be a somewhat heterogeneous group, right? Because they can be enrolled based on any one of these criteria. So this could potentially be a limitation. So can we consider a different randomized controlled trial? For example, a primary prevention trial. Is it time to think about preventing the first stroke in people with atrial myopathy but without AFib? Let's try to keep the patient population homogeneous. Let's try to determine what would be the most robust single biomarker for atrial myopathy. It could be an ECG marker, such as advanced interatrial block, abnormal P wave axis, or it could be an echocardiographic marker, such as left atrial reservoir strain. Oh, I should have mentioned that Ikeda recruits patients who are greater than the age of 45, so there's going to be a sizable middle age group. Perhaps a different randomized controlled trial should focus on an older age group where prevention of stroke and dementia would have the greatest public health relevance. And perhaps we should look at a composite outcome comprising ischemic stroke, thromboembolic events, and cardiovascular death. So, chairpersons, ladies and gentlemen, in summary, P-wave parameters or indices are ECG surrogates of atrial myopathy. Abnormal P-wave parameters and indices are associated with higher risk of cardiovascular disease and dementia independent of atrial fibrillation. Importantly, abnormal P-wave parameters and indices can help enhance prediction of outcomes such as ischemic stroke. And in terms of future direction, can we consider an anticoagulation clinical trial to prevent stroke due to atrial myopathy in the absence of AFib? I would like to thank all members, the PhD students and doctoral fellows and junior faculty in my lab, and also collaborators at the University of Minnesota, as well as my extensive network of collaborators in other cohort studies and clinical trials. I'm always indebted to the staff and participants of the ERIC cohort, and of course, I'm very grateful to the National Institutes of Health of the United States for allowing us to indulge in our intellectual pursuits. And here are some pictures of team members and collaborators. Thank you very much for your kind attention. It has been a delight to participate in this program.